All right, I think for the sake of time, we can go ahead and get started. Welcome to our Systems for Action Research in Progress webinar series. This is a series that we have every 2 weeks where we invite researchers from our Systems for Action research program to come and present on their research project and share some findings along the way. So my name is Carrington Lott. I'm the Deputy Director at Systems for Action, which is a national research program office of the Robert Wood Johnson Foundation. We're housed at the Colorado School of Public Health in the Health Systems Management and Policy Department. And at Systems for Action, we fund research all across the nation aimed at aligning delivery and finance systems across the medical, public health, and social services sectors. Today, you will be hearing from one of our wonderful grantees that applied to a research funding opportunity back in 2019. He has presented a few times in our Research in Progress webinar series, and his project titled The Impact of Global Budgets and Community Health Workers on Health Equity and Cross-Sector Interconnectedness in Vermont just wrapped up a couple of months ago. So if you have been following along with Dr. Atherley in his presentation series in our webinar series, then you're going to hear some exciting updates on how the project is wrapped up. So with that, actually, before we get started, just a few housekeeping things. Today's presentation will be recorded, and we'll send out an email with the recording as well as a PDF of the slides. And if you have any questions today, there will be a Q&A section at the end of today's presentation. So we'll have about 10-15 minutes for questions at the end. If any questions come up at any point during today's presentation, please locate your Q&A box at the bottom of your Zoom screen, enter in your question, and we'll make sure to address it at the end of today's session. Okay, with that, you are here to hear from our presenters, so I'm going to go ahead and hand it over to Dr. Atherley to introduce his project as well as the commentary folks that he has joining us today.
Okay. Thank you very much, Carrington, for that introduction. And for those who've seen previous ones, you'll see a little bit you've seen before, and maybe and also a few things you probably haven't seen as well. So again, I'm Adam Atherley. I'm at Virginia Commonwealth University, and I'm the PI of this project. And I just want to say before, as we get started, that, oh boy, have I had a lot of help in terms of people helping me do this project. I put the names of a lot of people up there who helped me with the academic piece of this, including Alina van der Broek-Altenberg, Lisa Nantkin, Jamie Benson. Mary Kate Mullman was the Health Services Research Director at Blueprint for Health, who really helped us write the grant. And there's just sort of, and you almost hate to put a list of names. There's so many people who've helped. And, you know, we've also had a ton of help from OneCare Vermont, who's been just terrific to work with. We wrote this originally with Blueprint for Health, which is another state agency. The Support and Services at Home, SASH program, we've been working quite a lot with too, and we're going to hear some commentary from SASH. And in fact, our commentary is, I'm joined by Liz Gange and with Casey Dormer, and I've got their bios up for there. And we've been they just have this I think really terrific community-based program that we've been working with them to kind of think through the economics and think about how do you trying to help them build the business case for what they're doing. And I'll say a little bit about what we found, and then what we're going to hear in terms of the commentary is their perspective on how the Vermont model has impacted their ability to deliver services in good ways and bad ways. The core idea that we have here is that we know that healthcare systems that reward based on volume favor high volume healthcare solutions that focus on those with a better ability to pay. And in contrast, systems that reward based on health will focus on the people who have the highest need, kind of in theory. And there's a lot of different ideas on how to move from a volume-based system to a value-based system or a health-based system. And one of the ways that people think about doing this is through global all-payer reimbursement. So the idea would be you give a fixed payment to someone who then spends it however it's most effective to try to maintain the health of the population. And obviously, the medical care system is one piece of that, but that would only be one piece necessarily on this project. And what we're trying to do in our project is really look at the effect of combining global all-payer reimbursement with things like community health teams to try to see if you can improve alignment and coordination between the medical care, social services, and public health sectors, and really look at the effect of that alignment on system alignment, health of the population, access to healthcare, and health equity. And our research question is whether or not realigning financial incentives in the healthcare sector is sufficient to create alignment between healthcare, public health, and social services. And my preview of the answer I'm going to tell you is no, I don't think it's necessarily sufficient. The second question would be, are there important differences in priorities and culture that would prevent alignment from happening? And as I'll show you as we go through this, our answer is yes. And then the bonus question that I added yesterday is, is the realigning the financial incentives necessary to create an alignment between the sectors? And I think the answer to that may be maybe. I mean, and again, try to think about the necessary and the sufficient conditions. Trying to create alignment without financial alignment, I think may not be possible, but creating the alignment may not be sufficient by itself to create alignment. So our setting is the Vermont all-payer model, and Vermont received a 5-year waiver from the CMS Innovation Center to allow all-payer accountable care organizations, and the initial 5-year waiver has now been extended. And the waiver was intended to incentivize a focus on value, quality, and population health, and create alignment between health system payers, providers, and community health teams. Essentially what this does is it allows the creation of all-payer ACOs, as it says there. So essentially what would happen is you have an accountable care organization, and they would receive funding from Medicare, Medicaid, private insurance, and then they would not, then all that money would come into this financial intermediary, and then they could then use that money to pay for health and healthcare however they want in a way that's removed from the fee-for-service system. So they could move away from volume-based care and really think about how do you innovate care to try to make your population as healthy as possible. This reform was layered upon previous reforms that had built community health teams in Vermont and also had created medical homes throughout the state. There's a preliminary analysis of the overall waiver, which was quite favorable in terms of the effect of the program on both health outcomes, mostly measured through the behavioral risk factor surveillance system, and also healthcare spending. There have been some challenges for the program in terms of getting enrollment, which turned out to be a little more challenging than was initially anticipated. So for this project, then, we're looking at alignment within each of the 3 sectors. So for public health, we were looking at community health teams. I'm going to tell you what we looked at with community health teams, but really looking at the alignment of the priorities between the community health teams and the broader population initiatives through the all-payer ACO. We also looked at the medical care sector, and we focused on primary care providers. And we looked at primary care providers' ability to engage with the new opportunities and challenges that came to them through the all-payer ACO. And then finally, it's the social services sectors. We work with the SASH program to try to look at measuring the value of the cost effectiveness of their program using standard economic evaluation. And what I want to do now is I want to walk you through each of these 3 pieces of the puzzle to try to give you an overview of what we found as we went through this project. So first, start with public health. So looking at the alignment of priorities with community health teams. So there's a statewide program of community health teams that's been in place for many years. These are multidisciplinary. They're regionally headquarters in each service area. There's 13 service areas throughout the state. And they've been funded since 2011 by a combination of Medicare, Medicaid, and commercial payers who take money and then route it through a public program, a state agency called the Vermont Blueprint for Health, and then they send the funds out to the community health teams. The community health teams have a tremendous amount of leeway to do what they want. So they're really working in they're really in the communities. They're working with their community partners, and they're able to work with their community partners to set whatever kind of priorities they want to. They have a lot of flexibility, for example, what kind of expertise to bring in. They just have a lot of flexibility. And what they do then is they connect patients to community-based services. They work with medical community providers to align the incentives and try to improve the quality of services for health and well-being. The challenge is that the community health teams are really working within these communities, and they've got this very, very important public health role. And then when the accountable care organization through the all-payer model came in, the thought is that they could also work with the all-payer model. And that creates this potential tension between the priorities of the centralized payers and the community stakeholders. And that's that question of alignment that we were interested in. So our alignment research question is, does the all-payer model create effective system alignment within the community health teams? How do the community health teams set priorities for what social, public health, and medical services to offer? And to understand how the community health teams think about trade-offs between health, health equity, and healthcare spending. To do this, we qualitatively identified the contextual factors that drive their decision-making, and then we quantitatively examined how the community health teams made priorities using a discrete choice experiment with a mixed logit model. So in terms of the identification of the contextual factors, so Lisa Nankin led that piece of our project, and that paper came out this spring in BMC Health Services Research. And so we talked with every single community health team in the state. The focus group that we ran focus groups, which included in every case, the community health team's leadership and then other people as well. And then what we found is there's sort of four big things that we heard from the community health teams. One is this stable and flexible funding really helped the local teams create their own structure and services. They were able to invest in building team capacity. They were able to do all kinds of things just because they have this payment level that is fixed and reliable. The second is they really cared about care coordination, and they really cared about individual care coordination for all the patients. The third thing we heard is that they were all about their communities. So really thinking about what are the key community partnerships, what are the local resources, also what are the needs of the communities. For example, one of the community health teams told us that there was no homeless shelter in their community at all. And so that means working with the homeless population became a priority for their community health team. And finally, that they really want to use their resources in a way that maximizes the health of the population, but that was kind of challenging because they didn't have good data either on the needs of their communities or on the effectiveness of different programs. So then to move beyond that, just these things are important and really see what is the most important to the teams, we did a discrete choice experiment. So we took these four themes and then we mapped those into 5 different attributes, which were funding, the target population, the program champion, whether or not it was in the community health plan, and the availability of data. And then we looked at how people would prioritize programs based on differences between these 5 attributes. We sent a survey to every community health team in the state of Vermont, including both the leadership and team members, and we looked at each of these discrete choice experiments that they did had 3 choices with 6 attributes. We had 180 responses, and they completed 2,520 choice tasks. And again, what would happen is, we would get this vignette, and we'd say to people, so suppose for the purposes of this study, you're in a position to decide the next program for your team. You're receiving $100,000 in new funding for one of 3 new programs, which vary in cost. All of the programs are equal in terms of administrative complexity, and each of the programs have strong evidence for their effectiveness. Any funds left over at the completion of the program may be kept by your community health team to support other programs. The new programs differ in the following ways. And then we described how these different programs were different in terms of are they in the community health plan, what population do they impact, and all those kinds of things. And again, I made the conscious decision putting this together not to show you the eye charts with statistical results, but just to sort of talk at a high level of what we found. So I'm going to show you 2 violin plots. And what this is showing is this is for the community health teams, what was most important to them. And this is just the dot shows you the mean of the result, and then the distribution is sort of in the thickness of it. So the top, and these are in order of importance by the team, with 1 being the most important and 9 being the least. And so you see, helping vulnerable populations was the most important thing to community health teams, followed by managing chronic conditions and connecting people to social services. And then when you get to the bottom, reducing healthcare system was the least important to the community health teams. And of course, the all-payer waiver and the contract that the state signed with CMS says controlling healthcare system spending is the number one thing that the state has to worry about. So there's a little bit of a disconnect between what the community health teams are thinking about and what the state is thinking about. And then we also asked them about the importance of who the champion is for the program. And the most important champion was local primary care. So local requests from your local primary care, followed by patient reports, followed by your local hospital. And all the way at the bottom is the state in terms of the blueprint reports and the all-payer ACO, which is called OneCare Vermont. They were the least important. So again, what you see here is that the community health teams really cared about those sort of local voices. They're really focused within their local community. Then what we did with this is we estimated conditional and mixed logit models. And essentially, again, what we found statistically is, again, the community health teams very much prioritize programs that were in the community health plans. Community health plans very much mattered to the community health teams. They did not necessarily prioritize the programs championed by the all-payer ACO. They also supported programs with evidence of effectiveness and programs targeting persons experiencing homelessness. There, we saw very consistently in our models a strong desire for and willingness to use more data if they could be given data. And then within the community health teams themselves, between the leadership and the members of the community health teams, we found very strong alignment. Okay, second thing is with primary care providers. So if you think about healthcare reform, most approaches to healthcare reform really envision an enhanced role for primary care providers. And we have very good evidence that robust primary care can lead to improved health outcomes, improved health equity, and all kinds of good things will happen. We also know primary care is not doing particularly well in this country for a whole host of reasons. So the all-payer model provide a whole bunch of tools to primary care providers to improve primary care delivery. The most exciting from a research perspective is innovative payment methodology, where primary care practices had the opportunity, if they wanted to step completely away from fee-for-service, and they could receive, for example, capitation payment for providing care. And there's just a tremendous amount of flexibility in terms of how primary cares were provided. And OneCare worked very hard with primary care providers to try to build innovative payment models that allowed primary care providers to really focus on delivering the care that they want to deliver. They also provide them improved resources. So again, money for additional services and all kinds of things along those lines. They provided data dashboards. They improved care coordination. There's just a whole lot of things that the OneCare, the all-payer ACO did to try to help primary care. But participation in the model is completely voluntary in terms of from the provider perspective. So the way that joining this all-payer model works is that it's all about the primary care provider decision. So each person in the state is attributed to a primary care provider. And if that primary care provider opts into the model, then the patient is opt-in, sort of passively ends up being opting into it as well. So participation from the primary care provider perspective has several advantages. Again, there's additional funds for care coordination. We have this option to shift away from fee-for-service payment. You can get population health management payments per attributed beneficiary per month. There's data that comes. You get a SNF waiver. There's post-discharge waivers. There's telemedicine rule waivers. There's just, just really creates both extra resources and extra flexibility in terms of how you deliver primary care. So you've got all these different avenues to improve primary care delivery, but ultimately, the success of the program from the medical care perspective is going to depend on the ability and the willingness of the primary care providers to accept and use the tools that OneCare is offering them and alter their care delivery practice. But in order for that to happen, you have to have primary care doctors actually know what's happening. I mean, they have to be aware of these extra tools. They have to be aware of all these opportunities. They have to sort of know what's going on. And so working with OneCare, the question is, to what extent primary care providers understood the changes within the system and were changing their practices in response to it. So we did this very extensive literature search to try to find a measure, and we didn't find one at all. So we decided that we would go ahead and build one. So again, any kind of healthcare reform is relying on primary care providers to alter their care delivery in response to new incentives and resources. And whether providers act on these is unknown. And again, there's no instruments out there to really measure primary care provider engagement with the all-payer model. So in this piece, then, we developed that measure. So we developed an instrument based on the self-efficacy theory of the adoption of innovation. And there's a couple of different theoretical paradigms that could really drive this model. You can think about a cost-benefit paradigm or the adoption of innovations, but the basic idea of this, which goes back about 50 years, actually back into the 1970s, is that when you put an innovation in place for people in the workplace, whether or not they adopt it is based on these two underlying constructs, which is how easy is it to use and how useful is it for my job? And innovations will be successful if they're both easy to use and people who are working find them useful. So what we did is we took a measure that was actually for adoption of email, and we updated and modified that to try to look at the adoption of healthcare innovations. And we built the measure around these two constructs. So perceived usefulness, again, the degree to which a person believes that using a particular system would enhance his or her job performance, and ease of use, the degree to which a person believes that using a particular system would be free of effort. And we extended those ideas to the adoption of the OneCare approaches to care. And so when we adopted this, and we ended up with 13 questions for this usefulness scale and 9 questions for this ease scale. And then each of these 22 questions are on a Likert scale from strongly agree to strongly disagree. And I don't want to spend the time to let you go through all of these questions, but these are the 13 questions for usefulness, just to give you a flavor for it. My job would be more difficult to perform without OneCare Vermont. Working with OneCare Vermont saves me time. Participating with OneCare Vermont reduces the time I spend on unproductive activities. No, that's, again, trying to get that question of how useful is this? And then the second construct is perceived ease of use. I'm often confused about the services offered by OneCare Vermont. OneCare Vermont is rigid and inflexible to interact with. And then we asked 4 background questions. I know what an accountable care organization is. We use the term OneCare Vermont in this, which is the only statewide ACO. I'm more accountable in my member practice because I'm in OneCare Vermont. I'm in OneCare Vermont by choice. OneCare Vermont rewards me for good outcomes. And then we asked some questions about what type of provider they were, their practice type, and also we asked them to estimate their percentage of patients that practiced in the ACO. So with the psychometrics, then, we wanted to look at 3 relationships. First, we needed to know the number of latent constructs. We hypothesized there should be 2, and then we needed to show that the measure was both reliable and valid. For reliability, we're measuring it using Cronbach's alpha, which is the standard approach to it. Validity is always the trickier piece of this. So for validity, we built that based on theoretical relationships with convergent and divergent validity. And our idea was that usefulness should be positively associated with the perceived proportion of the patient population in the ACO, being in the ACO by choice, and being rewarded for good outcomes. But ease of use would not have these positive correlations. So if you, for example, if you've got some data dashboards, or you know about a reward, if a whole bunch of your patients are in the program, that should make that data more useful, but it doesn't necessarily make it easier to use. So the idea is that if these constructs are working the way we think they are, we should see strong correlations with usefulness, but not so much for ease. And again, I'm not going to give you the eye charts associated with the factor loadings. I'll show you this one just because it's really cool. This is the scree chart of the eigenvalues after we did the factor loading, and this just sort of everything we did popped out with the 2 factors just as cleanly as you can imagine. We did do a pilot testing. We pulled 3 items out that the pilot tester told us weren't good. 4 items failed to load on a single construct, so we ended up with 17 items in our final measure. In terms of reliability, we had a Cronbach's alpha of 0.95 for usefulness and 0.83 for ease, which are both extremely high. In terms of validity, we did see the relationships that we expected. So the you see that usefulness, we thought that would be positively correlated with the patient population, the ACO being the ACO by choice, and we're working for good outcomes. And again, we see not only the positive correlations, but we see the correlations are stronger as you sort of move down the risk, which is what we anticipated. And then we thought that ease would not have that negative correlation. In fact, we did not see that. We currently have I should mention that for the discrete choice experiment study, the first one I forgot to mention. So that's in press right now at Health Services Research. For this study, the manuscript is currently in preparation. And then the third thing we did is we again worked with Casey and with Liz to try to look at the cost effectiveness of the SASH program. And again, just a brief program descriptions. The SASH connects older adults and individuals with disabilities who live in affordable housing properties or the surrounding communities with support services and community-based healthcare. The housing with services model is delivered to panels of approximately 100 participants who each have a full-time SASH coordinators and a quarter-time wellness nurse. Most of the panels are nonprofit housing organizations. And again, the goal is to try to promote greater care coordination, improve health status, and slow the growth of healthcare expenditures. And I think Liz and Casey will say more about this and certainly know more about this than I do. But a lot of the population in the SASH program, they're sort of at-risk older people, and you're trying to keep them living independently. And so the research question that we're working on them with is this idea of, can a community-based program funded by the all-payer model show that the gains in health justify the spending using standard economic evaluation approaches? So essentially, are the gains in qualities sufficient to justify the investments by the ATM using standard economic thresholds? So to do this, we calculate the gain in life years associated with the improved health during the program. And again, the data that the SASH program has collected, I find just stunning in terms of the health impacts the program's able to have on these at-risk individuals. And then we calculated the cost of the program, and using those two pieces, we could calculate an incremental cost effectiveness ratio with the cost per quality adjusted life year gain. To do this, we built a Markov model. This is based on earlier work that I did with Lauren Smith and with John Campbell and others, looking at a community-based intervention for cardiovascular disease. So we use a cost utility analysis with this Markov model. We have 7 mutually exclusive states, and we move people through these different, starting in normal health, and then move them through the model based on transition probabilities, with the transition probabilities changing based on the intervention that SASH did that reduces their risk factors. And this is very much work in progress that hopefully will be in manuscript form within the next couple of weeks. But what we find is that the changes in health status very much lead to improved health and substantial gains in qualities. And again, we're still working on the precise numbers, but the cost per quality gain is going to be well below, the usual, wherever you want to put the threshold, it's going to be way below $100,000. So it's going to be, in terms of the way we think about the value of health interventions, it's extremely cost effective. And under some assumptions, it looks like it may actually be cost savings. And again, the challenge here in most places in the world is that although the program makes a lot of economic sense, none of these cost savings obviously are captured by SASH. They're all captured by Medicare, by Medicaid, by different other agencies. And again, this is a challenge in terms of the replication of the model. So in terms of the summary of the findings and conclusion, if we put all these pieces together, the all-payer model doesn't automatically create system alignment. And in particular, when you think about the community health teams, that they're prioritizing local needs and local voices. And so the statewide priorities are not hugely important to the community health teams, which have strong internal alignment. But, I'll come back to that. The primary care providers really, the message that we got from our survey is that they're focused on day-to-day care delivery needs. They're coming in and they've got a line of patients out the door, and they're trying to give them the care that they need. And so thinking about things like, how do I work with a payer model isn't necessarily where they're thinking about it. They're thinking about how do we keep people healthy. And the opportunity for sustained funding for cost-effective community approaches to care like SASH This is a piece I think where again, I'll let Liz and Casey talk about the success or challenges that they have. But so there's a little bit of a disconnection between state and community health systems or primary care goals, but not completely. And one of the things, if you look at the community health teams, they, their number one priorities are really about doing care coordination and about helping people with, multiple chronic illnesses. And if you think about trying to hit your cost goals from a centralized perspective, that's the population you want to work with. And so everybody is very much laser focused on this high need, high risk population, whether it's to keep them healthy or control healthcare spendings, that those goals are very much in alignment. So there is a real good alignment between the overarching goals of everybody involved in this healthcare system. But it's just, that's why I say, and this really creates the opportunity for alignment. But again, it's sort of, this is maybe we might say it's necessary, but not sufficient, because again, if you want to move beyond this, really creating the alignment, you need consistency between the statewide population health goals and the health goals of community health plans. Again, a lot of especially the community health teams are really looking at those community health plans. And so if you create an alignment between that community health plan and the statewide population health goals, your alignment's there. Same thing in terms of common covered populations, that this is, again, back to the community health teams. This is obviously a challenge for them, and also for the primary care providers, that they're helping these populations. Not everybody's in the model. And again, because you have a voluntary participation, I said very early in this talk that the enrollment goals were not met in the way that had been hoped. And there's a lot of just implicit challenges in the way you do a voluntary system. And so to the extent you create commonality in covered populations, that's going to make it much easier to do this creation of alignment. Common data on program effectiveness. And, again, I think that's both having the programs like SASH generating data that can go to the OneCare and show them that these programs are really effective and make a lot of sense. But also the other side of, or the community health teams in particular, are starved for data. And so if you want to get them to work on a certain, on statewide goals, give them data on what programs are effective and the needs in their community. And that should just happen right away. Payment mechanisms are also hard. I mean, especially we've got these cultures, and whether it's fee for service or whether it's working with community partners. And so the cultures of these different organizations are built around the existing payment mechanisms. And so trying to change the payment mechanism is going to be harder than it seems, because a lot of the culture and the structure of the programs are designed around the way they're paid. So you need to really have a conversation. Again, I think OneCare has been very good about this, because they put out something called Care Navigator to try to work with community health teams and reimburse them for extra services, and it didn't work. And then they stepped back from that. And again, finally, just being awareness of the differences in culture with your different partners and how their priorities may be different. So if people have additional questions, please feel free to contact me. And I'm happy to share what we have and have further conversations. And from there, I want to turn to Liz and to Casey to talk about the SASH program and give some commentary.
Mm-hmm. Great. Thank you so much, everybody, for having us. And thank you, Dr. Atherley, for including us in this conversation and for all the work you've done with us over the past year. It's been really, really wonderful. So I'm just going to talk briefly about SASH. You can go to the next slide. So SASH is a model that brings together a partnership among community organizations and agencies in housing and healthcare. We're based primarily in nonprofit affordable housing, and we are, as Adam has said, a part of Vermont's all-payer model for healthcare improvement and payment, part of the payment reform initiative. And one of the great things about being a part of that is our ability to target high-cost and high-risk populations in in our housing units. When we do that by focusing on evidence-based wellness and prevention to serve a whole population, we do that with embedding a SASH coordinator, a community health worker, and a wellness nurse into our housing to be able to support participants where they live. I'm going to turn it over to Liz to talk about a little more detail about how the program is funded, and then I'll talk a little bit about our results and challenges. Go to the next slide.
Thanks, Casey. Yeah, so SASH has been funded under the all-payer model, or OneCare ACO, for more than 5 years now. You can see on the left is sort of the chart of our funding stream. And that funding that goes through OneCare is specifically from the Medicare Shared Savings Program. So OneCare pays Cathedral Square. Casey and I are both oversee the statewide SASH program, but our employer is Cathedral Square Corporation. That is the statewide administrator. But the great thing about this payment process is that we get paid in advance. So OneCare is paying us in advance on a quarterly basis. And then we disseminate the funds to serve the panels around the state, about 63 panels total of up to 100 participants, to 22 different housing organizations. So the nonprofit housing organizations are all getting paid up front, and we serve about 5,000 participants at this time around the state. So this allows us, again, like Adam had mentioned, stable income for our program. We can plan, implement our programming, and this funding goes directly to staff. So this funding that's coming through OneCare is about $78,000 per panel, and that goes right for a full-time coordinator, community health worker, and a quarter-time wellness nurse. You see also, though, Casey and I also are part of the administration of the program with all of these programming, education. We have the data management platform. So we also get funding for that administrative piece of the program through the State of Vermont Department of Aging and Independent Living, Disabilities, Aging, Independent Living. So that's State of Vermont funds, and also some from the Medicaid Global Commitment funding. So just to give a little piece of that picture. So again, we contract with OneCare, SASH, or Cathedral Square contracts with OneCare on an annual basis. And we've tailored our contract with OneCare as best we can to meet our general needs. And we are required to report to OneCare, but at the same time, we're not really fitting their boxes, which I think is a big point of this presentation, is that, other organizations, for example, that might be under the OneCare umbrella are actually getting paid based on the work they're doing. They're getting paid afterwards. They are showing their payments based on performance. Whereas in SASH, we get paid up front, which is super. And our reporting just doesn't fit quite the box that everyone else has to be doing. So the goals aren't always in alignment. You could go to the next slide. I just wanted to share also that in 2019, we had finished up an independent study that did show that SASH statistically did save on Medicare funding and also Medicare and Medicaid funding. So this is super. And like what Adam has commented, that it's great savings, but it's not saving we still have the same cost for our staff and for our programming. You can go to the next slide. Yeah, this was I was going to show you, it doesn't show all of I think it drops down all of the content, but I'm not going to read through it. Just the path of how we've been funded, and our future is we are continuing to work with the state of Vermont and continue to be part of an all-payer system, because it is working for us. And the new CMMI application for the future is called AHEAD. So our plan is to be part of that under the state of Vermont going forward in 2025. You can go to the next slides. Yeah, you can go through all this I forgot about that. Thanks. Here we go. Casey.
Thanks, Liz. So one of the major initiatives that we have been exploring in the past year is a 5-year look back at our hypertension initiatives at SASH and looking at change in blood pressure over time. With the nurses have very specific protocols on addressing hypertension in participants, identifying hypertension in folks who are undiagnosed. And there is a whole protocol for nurses that they follow when somebody has a high blood pressure. And one of the exciting things is seeing how we have been able to change our rates of hypertension over time from starting this work. And a lot of this work was in partnership with the Vermont Department of Health and funded by the Vermont Department of Health. So you can see a significant increase in blood pressure management. To 96% of our population have a blood pressure that is under control compared to national data. That one of the challenges with this work is that we obviously are not doing this in a vacuum, that SASH addresses blood pressure in partnership with all of our partner agencies. And one of the beauties of OneCare and that model is that it brings us together in regular meetings. But one of the challenges is really identifying who is having the impact, who is having the most impact, because it varies on a very individual basis with participants. So we're seeing change in blood pressure, but is that because we are bringing people to primary care, or is that because we are connecting them with the food bank, or connecting them with home health or mental health or transportation? So there's so many ways that we make a difference. And Dr. Atherley's work is showing that that the ability to reduce blood pressure is a significant savings, but that is kind of covers a lot of different organizations and the work of a lot of different organizations, not just SASH. So the ability to step back and say, this is the intervention that worked, is really difficult. The other point I'd like to make is that when we're looking at cost savings, we're really talking about how do we measure prevention. And so much of this model has really been wonderful in that we can focus on prevention and we can focus on individual health needs, but it makes it hard to measure and makes it hard to say we prevented a fall or we prevented a heart attack. And how do we quantify that in a meaningful way?
Wonderful.
I think that's back to you, Carrington.
It is, yeah. So I think we can stop sharing the slides for now, and then when we're finished with the Q&A, I'll ask you to put this back up so we have a few more announcements. Thank you, Dr. Atherley and Liz and Casey, for coming and presenting and talking about this really important work that's happening in Vermont. I think we all learned a little bit here, and now is your chance to ask any questions that came up along the way, large or small. I do see that we have 3 questions that have been entered into the Q&A box, so let's go ahead and get started with those. The first one from Robert Law is behavioral health included in the global budget? And if so, how?
I'm not sure. I believe it should be, because I think that what you're doing essentially is you're for everybody who opts in, you're doing a risk-adjusted payment for all the healthcare that I guess would have been paid for by their organization. So it would be, for example, somebody's on Medicare, you're doing essentially you're paying them based on a per capita estimate of what they would have spent in the fee-for-service sector. So I think anything that would be covered under whatever insurance program you're in, be it commercial insurance, Medicaid, or Medicare, would also be covered under the payment. Liz and Casey, I get that right?
I believe so.
Yeah.
Great. Thank you for answering that. Another one from Robert Law. Does the global budgeting have flexibility permitting direct spending to address social determinants of health, for example, housing and food insecurity?
Yes. And Liz, and you guys want to talk a little bit about how you guys do that? I mean, because that's kind of your program, I feel like, in a lot of ways.
Yes, that's exactly our program. I mean, that is what OneCare is paying us to do, is directly target social determinants of health. So our SASH coordinators, our community health workers, and our nurses are working a lot on connecting people with transportation, on connecting people with various services to maintain their housing. Liz, do you want to add more to that?
I was just thinking about, you know, one of the core things we do in SASH is we do an annual assessment with our participants, and within that, they're validated screens, social determinant of health screenings that we've been doing for over a decade. And what's interesting is that, and we have relationships with our participants because we are in the housing communities and we're there every day, and we have an office there. And we have this information over time and know them personally. So it's just been a great link that we've seen that the participants have this trust in this person that they see on a regular basis and their nurse, that that they're talking to us about these things. And then we can in turn share what we need to with the primary care or the designated agency and that kind of thing. So that's how it's been working.
Yeah, and I'd also throw in, just in terms of, for example, with the community health teams, you know, kind of the good and the bad of what's happening with this model is that the OneCare's put a lot of money into community health teams, and they've done things like embedding community health teams in primary care practices, and the kinds of things we're talking about, you know, that's what the community health teams are very much doing. You know, the challenge is that OneCare, you know, they want to see information on what exactly is being done, who's being seen. You know, there's also an issue of not everybody's in the ACO. And so that means, you know, the traditional model for the community health teams is if you need help, they help. And now it's a model, now you're sort of moving to a model where if you need help and you're in the ACO, then you have help. So that's a culture change. So that's the hard part. But the good part is they're putting a lot of money into community health teams, and they're embedding community health teams in the primary care practices. So it's really pushing things in a good direction, but just there's a lot of challenges in making that happen. Thank
you all for expanding on that. We have another question in the chat or in the Q&A box, and that is from someone who is anonymous, but their question is, given federal and state prioritization of multi-payer models, what are your recommendations on how to align federal and state priorities with the local community priorities?
Yeah, so I mean, I think from what we heard, I mean, that there's a couple of pieces, you know, from the primary care provider perspective. I think that what we saw pretty clearly from the data is that as a greater proportion of the members of the practice were attributed to the ACO, it became more, you know, the tools became more and more useful. And the way the challenge is that you can put Medicare, Medicaid, and commercial insurance in, but you can't put, for example, self-insured insurance plans. There was actually a loss. Vermont tried a lawsuit, and they lost, just like trying to get around the ERISA provision in federal law. And so that means you're never going to have 100% of the population in the model. And so that means but I guess hopefully there's some critical point where you have enough of your population in that you're going to start to change the practice behavior. And so that's one piece of, just as more people participate, I think hopefully you'll get better alignment. And the other thing is just more conversations. Again, you know, really thinking about, for example, those community health plans. And when you're writing out the contracts, you know, thinking about what's in the community health plans to make sure that there's consistency between what's being prioritized locally and what's being prioritized at the state level, and also maybe feeding some of the state priorities down into local community health plans.
I would add two things to that. One is making sure that there is a lot of communication with those local organizations about what they see as the needs, and having current relevant data available. I think that there's a pretty significant lag in data where it's 2 years old, which the folks on the ground are seeing things right now. And so 2-year-old data is really hard for them to prioritize their work around. So that would be really important.
Some great insight. Adam, I see you leaning in. Do you have something else to add? Or
no, I was just reading the questions.
Okay, great. Oh, another one came in from Erica Coletti. So their question is, I think I heard that the coordination connection to social supports is funded as a key part of this model, but it's not clear if the actual support services like housing and food are funded. Would you share if the services themselves are funded for SDOH needs?
That's a great question. So not directly, no. So what so the SASH model, really, we have a collaborative partnership and a multi-year memorandum of understanding with other partners in the healthcare community, the hospitals, the designated agencies, community health teams. So we and I'm sure I'm forgetting other partners, and they could be local. So even though we're a statewide program, the local regions have their own collaborative. And within that, the participants know, like when I talk to my SASH coordinator, I know that person's going to be, connecting me with all these people, plus the other folks that I put on my use and disclosure. So we do get grants. We do, like Casey mentioned, get funded for programs through like the Department of Health. We do a lot of education. But for the most part, we're leveraging each other. So we're really working in that sort of a model. And our funding goes to staffing, and then the administration of training and keeping people up to date. And again, that data management and so on.
Thank you, Liz.
You're welcome.
Okay, last chance to ask any questions. I don't see any popping in now. Before moving on to announcements, one just came in. All right, let's move on to this one. Question from Jan. Can you say how ACH is working with community hospitals fit into community plans and Vermont's OneCare?
ACHs?
Did I mean ACOs?
Not sure.
Jan, do you want to put into the Q&A box some clarifying information here for your question?
I just wanted to say while we're waiting for Jan to clarify that question, I think one thing that will be super interesting for research that Dr. Atherley is doing is, looking at that chart of the Violin chart that you created with the community health teams, is whether long-term their hyper priority on high needs population leads to OneCare's priority of improved healthcare spending.
Thank you, Casey. I see that Stephanie put into the chat that accountable communities for health. There's one in every health service area of Vermont.
Yeah. I'm not sure the answer to that question.
Okay. Liz, Casey, anything to?
I can say that, we are very familiar with our ACHs and OneCare, like that. That's how they talk about their population, is by the location of the state of Vermont. And they're great conveners, right? They convene. They just went through the different areas and how is the health of your region, and all those indicators and indicators for what we're looking at in 2024. And hospitals are certainly part of that, and leaders in that group as well. I don't know if that is helpful or not, but
thank you, Liz.
Yeah.
I think we can move forward to some systems for action announcements. So Adam, can I ask you to share your screen again?
Absolutely.
All right, thank you so much. So as I said at the very beginning of this presentation, this project responded to a call for proposals that we put out in 2019. We typically put out a funding opportunity annually. We are anticipating releasing our next funding opportunity mid-December of this year. We are seeking ways of helping the medical, social, and public health systems work together to dismantle systemic racism. We will have 2 different funding categories. So we'll have a developmental study that will be about a year's worth of 12 months, and it's what we consider a pilot study. And then there will also be an impact study category that you can apply for, which should have a completed pilot study of the proposed approach. And then this year we do anticipate doing a 2-stage proposal process. So we'll have a brief proposal phase and then invitation for full proposals as well. So more information coming about that funding opportunity in the coming weeks. Can I get you to go to the next slide, please? And this is an ongoing ResProg series. So our next presentation will be from our research team at the Coeur d'Alene tribe. They will be presenting on their core adolescent support team referral dashboard project. So that will be November 29th. If you're interested in attending for that, we will send out a registration link in the follow-up email, and it will also be in the PDF of the slides. Is there another slide? That is it. Okay. Thank you so much for attending today for the Research in Progress webinar series. And thank you so much to Adam and Liz and Casey for coming and presenting and being part of this. I think we all did learn something new, and it's very exciting work. So thanks so much for joining, and I hope everyone has a great rest of their day.